How's it going, everyone? Dr. Todd from Move Now University and from Gonstead Spine and Wellness, our clinic out here in Meridian, Idaho. Yes, I actually practice full time, and we teach chiropractors how to put functional movement into their chiropractic practice in 90 days, 3 months. What I'm going to talk about today is the 4 laws of functional movement. If you had to break it down to the 4 most bare bones minimum things to start with, just to conceptualize and apply this to your patients that will help deliver results immediately. What are those 4 things? We're going to break those down. Let me just make sure that we have a good connection here. There we go. We do. Good connection. Awesome. Have to make sure that I've learned the hard way of getting in and sharing lots of quality information, then finding out that our microphone's not working or something's funky. So give me 1 second. Let me make sure we get this shared over here. And 1 second, we'll let a couple more people jump on. This is going to be a good one. You're not going to want to miss this. And we'll get rolling. Okay. So the first thing I'm going to talk about, the first law, let me pull this up on the screen so you can see it. Let's see how this works here. All right. We have, let me get fancy. Okay. 4. And let's see if it shows up. All right. The first one is to work mobility before stability. So what does that mean? That means that there's certain patterns throughout the body that are inherently more immobile. There's a thing called the joint by joint approach, where if you start from the bottom up and you look at a human body, there's certain joints and regions that are more predisposed to having mobility issues. They found that if you improve the mobility stuff first, then when you get to the stability stuff, you'll have a better impact on the patient. So let's start with the joint by joint approach to cover that, and then I'll jump back and I'll explain the mobility then stability thing. So if you start from the bottom, the foot. Okay, so technically most people start with the ankle, but I'm going to start with the foot. The foot, should it be mobile or stable? And technically the foot should be stable, and then the ankle right next to it should be mobile. And most people have ankle mobility issues. Okay, so that's a first joint that you should start to work on improving mobility. What's the main movement that a immobile ankle affects? And that would be a deep squat. It's difficult to get into a squat when you have ankle mobility issues. That's the number one reason people have problems getting deep in a squat, is from the ankle first. Not the only reason, but that's the first thing you want to clear and look at. It's very common. As you move up the chain, you have now a knee. Remember, this joint by joint approach, it goes mobile, stable, all the way up. So if the ankle should be mobile, the knee should be stable. You don't want that flopping around, obviously. As you go up to the hip, should the hip be mobile or stable? It should be mobile. And most people have hip immobility, which then leads to having to bend and move at the lumbar spine, causing problems, because the lumbar spine, the next region, should be stable. Core stability, lumbar stability. Then as you move up a little bit higher, you get into the thoracic spine. Should the thoracic spine be mobile or stable? It should be mobile. And most people have thoracic hypomobility issues, especially with thoracic hyperkyphosis and thoracic rigidity. Then as we move out into the extremity, we can look at the shoulder blade, the scapula. The scapula should actually have stability to it. People have lack of stability in the scapula. It leads to glenohumeral joint problems, right? So you want stability in the scapula, mobility in the glenohumeral joint in the proper shoulder itself. As we get up into the cervical spine, you want to have stability in the cervical spine. Doesn't mean hypomobility, doesn't mean fixation in the intersegmental joints. You know, us as chiropractors obviously want joints to be moving smooth and free and proper. But a lot of times in the cervical spine, people lack the stability, the ability to stabilize the neck, which then leads to traumas, more trauma, I should say, because typically it's a trauma that causes these problems to begin with. So that is the joint by joint approach. Now, speaking to this number one law, this first law is you want to work mobility before stability. Best example would be, or best example of what not to do would be working with a patient in an exercise format and really going hardcore into all this, advanced core activation when the person can't even bend over to touch their toes. Here's why that's an issue, is because your body first needs to trust and learn how to move from point A to point B. Okay. So bending over to touch your toes, for example, let's just talk about this topic because this is, I think, one of the best examples of where functional movement, this term functional movement, comes into play with how we move. When you bend over and touch your toes, let's say you have someone do that and they can't touch their toes. They go into a toe touch, they can't touch it, right? But then when you sit them down and they do a long reach and they stretch forward to touch their toes, they can touch it. What's the difference from the standing position to the sitting down position? The only difference is the position of the patient, and you change the gravitational load on their body. When they're standing and bending forward, they require some stability to get down into that position to touch their toes. If they lack stability, so if the brain says, "Ooh, I'm bending forward at the waist, my spine's going to start to shear forward. If I have good core activation, the core is going to stabilize the spine so I can trust to allow the posterior chain and the muscles in the back part of the body, like the hamstrings, for example, allow them to elongate so I can complete this toe touch pattern." If you don't have that core activation and stability, then the timing of those two movements is off and your body puts the brakes on the muscles. So you have this inherent feeling of stiffness or issue there when the problem's not really a muscle length issue. It's more of a guarding issue. It's a motor control issue. It's a brain trying to protect you from doing something that's going to be hazardous. So now if you sit down and you have your patient sit down and they stretch forward to touch their toes and they can make it, then it means that it was simply a motor control issue. These kind of tests exist all throughout the body. It's kind of fun to go through and figure this stuff out and prove this to a patient as well. But let's say that the person sits down, they bend forward, they can't touch their toes when they're sitting down, just like they couldn't when they were standing up. What does that mean? Well, that means that it is a tissue problem. It is a muscular restriction or some kind of tissue restriction or musculotendinous junction. It could be a joint issue, but in most cases, it's not really going to limit you that much in a joint unless it's, super rigidity in the lumbar spine. They can't even flex forward in the lumbar spine, or super rigidity in the hips that they can't even bend forward. But in most of these cases, it is a motor control or it is a muscular issue in a toe touch pattern. The reason I went off on this tangent talking about this pattern to talk about the first law of functional movement as far as working mobility before stability is because most of the time what we see is that even if someone had a stability issue that started this abnormal pattern, like meaning they flex forward to touch their toes, brain doesn't trust that movement, puts the brakes on the muscles, rinse, repeat, allow that person to exist like that now for a decade or two. When they come in and see you, their tissue is so guarded that the tissue has turned into a problematic source of the problem. So now you have to work at elongating tissue, or I should say technically it's desensitizing tissue so that you can get from point A to point B, because the science shows that all the stuff that we're doing doesn't have really permanent effects at keeping that tissue elongated. It has to be fixed at the neurological level, has to be fixed at this motor control level. But I digress. You want to work mobility first before you get into stability. So in the toe touch pattern, if there's a mobility issue, if you do this test and there's a mobility issue, you need to work at desensitizing the posterior chain using tools like a foam roller, which is what we call global mobility, using focus mobility like a double lacrosse ball or a J cane, or like other tools that can get into tissue a little more exact and more precise compared to like foam roller. And then you need to go through and start stretching, doing extensibility. But then after that, that's when you need to start doing some type of motor control repatterning, like a leg lowering drill. All right. So a leg lowering drill helps with that. I'll make another video showing this sequence maybe, or sharing what some of these exercises look like, so it's a little bit easier to conceptualize. And then once you've patterned this, now you have to load the pattern to seal the deal and get the motor control component online. So how do you now pattern a toe touch? Well, first you have to learn how to hip hinge properly, which is just guiding and cueing movement, hip hinging, shoving the hips back like in a deadlift type position. And then, spoiler alert, that's the movement that you have to jump on to pattern this this movement neurologically from a motor control standpoint is you load the pattern through doing some sort of banded deadlift or kettlebell deadlift or barbell deadlift. But a deadlift is a very good pattern to reinforce this motor control issue. Once you've worked mobility, you've done some stretching, some extensibility, you've pattern reinforced this with like a leg lowering drill, so to speak, and then you can jump into a deadlift. Now, do you have to go through that sequence forever with someone? No, because once you start to change how the brain and everything operates, then you get into a brief warm up and you can get straight into actual exercise for strength and power, like the actual deadlift itself. And you don't have to spend, 30 minutes just going through these corrective exercise and functional exercises. Not to say it takes 30 minutes to do what I just explained, probably takes 5-7 minutes. All right. Next piece of this. So mobility, then stability is the first one. The second one up is clear the neck first. So what does that mean? That means that there are all these different patterns of dysfunctional movement. We have them split up into 8 different dysfunctions. This is how we teach it inside of Move Now University. We go cervical is D1, D2 is thoracic, D3 is shoulder, D4 is scapular, D stands for dysfunction. D5 is core, D6 is posterior chain, D7 is hip, and D8 is squat. So those 8 patterns, the reason we got cervical as D1 is because what the best science shows is that your cervical spine, the cervical patterns, the ability to rotate side to side or flex and extend or rotate and flex, all of these movements are a primary pattern. It's a primary pattern, what we learn from a developmental standpoint when we're a little baby. And it's a primary pattern that ties into a lot of other movements in the body, especially the shoulder and thoracic spine. And they found that if you clear those patterns first, you'll get a lot of carryover into fixing other movement patterns elsewhere. So that means someone comes in, they have some dysfunctional low back stuff and low back pain, and that's their main screaming thing, but their neck doesn't hurt, but their neck's dysfunctional. Does that mean you pay zero attention to the reason that they came in and not give them anything helpful or guiding in their low back or pelvis, and you only work on their neck for several weeks while they lose their mind and say, hey, can you address why I came in here? No. Obviously, what you want to do is address what brought them in, but you want to make sure that you're clearing out the dysfunctional patterns in the neck if they exist, and not ignore those just because maybe because they are maybe asymptomatic. Okay. So there's a certain order of operations is what this second rule talks about. Clearing the neck first is one of those things to look at the order of operations. Really, mobility, then stability is another rule to help you figure out what order of operations to attack with a patient when they are dysfunctional. So I guess the first thing that I should say is you have to do a movement test. So a movement assessment to measure the actual movement, identify what's abnormal before you apply a corrective strategy. And then you remeasure, you retest to see how they did, if it worked. And you follow these rules, then this sets you up for a good game plan as far as starting to figure your patient out. Okay. All right. Third rule here. Third one is prioritize clearing non-painful patterns first. So what does that mean? That means if the person comes in, and remember there's these 8 different dysfunctional patterns that I just talked about. So let's say you do a movement assessment and you find out that, let's say hip, so D7 was dysfunctional, but it wasn't painful. It was just really dysfunctional. They have poor range of motion. They can't get into like a Faber. When they go into like a Thomas test, it shows that their hip flexors are problematic and just stuff screwed up all over the place. All right. Let's say that that's non-painful, but when the person does a squat, their knee valgus collapses and it hurts in their knee. And let's say that their ankle hurts too. Okay. I mean, I'm just throwing this out there. This isn't the most common thing that you see, but let's just say that is. So hang in there with me so I can prove the point. So in that case, let's say the person's knee and the ankle was really painful. And anytime you try to move it in any sort of way, or not any sort of way, but anytime you try to do like direct strategies for the knee or ankle, it was hurting. The person's grimacing. Oh my gosh, this hurts. Well, first off, you have to differentiate between, does it hurt or is it just challenging? Is it a stretch? Is it difficult because they haven't moved that body part in a while? That's different than pain necessarily. But let's say it's searing, sharp, shooting pain that would force them to try to navigate around that pain to get from point A to point B, which then in the long run is not going to help your mission of restoring proper movement, because they're going to move in this dysfunctional pattern to try to achieve what they think you want them to do in this exercise. So the moral of the story is, do not work that painful pattern. Work the non-painful dysfunctional pattern, their hip. So go through and work mobility. Remember, mobility first, then stability. So work mobility in the hip. There's lots of mobility drills to do in the hips. Lots of, using tools like foam roller, lacrosse ball, J cane, and then going into various types of patterning, stretching, patterning, and then reinforcing, and then loading. And you can do all of that. And the nice thing is while you're doing that, the person's going to say, wow, you know what? Ever since you start freeing stuff up in my hip, my knee is not bugging me as much. And my foot and ankle really doesn't hurt. Isn't that silly? Isn't that weird? Silly, right? It's because when you fix a painful pattern, when you fix a dysfunctional, non-painful pattern, that has carryover into the body starting to trust proper movement again. And maybe some of these other joints or body parts that were painful, the pain starts to go away and you realize, oh, that wasn't really a key primary concern to begin with. I followed these rules, I followed the sequence, and the body started to heal itself and work its way out. All right. And then the fourth and final rule that I'm going to talk about here is, in shoulder cases, clear T-spine mobility first. Now, this kind of ties back into the mobility then stability issue, but a little further, because the shoulder, remember I was talking about the joint by joint approach, and I was saying the scapula should be what? It should be stable, and the glenohumeral joint should be mobile, right? So like when you bring your arm up, your scapula should be able to stabilize against your thoracic spine and move in that nice pattern. It shouldn't flare off. It shouldn't be flopping all over the place. That allows the glenohumeral joint to have the proper range of motion, so the scapula doesn't dump forward. And then when you bring your arm up, it hits that chromium process, and now you have impingement in front of the shoulder. And it's a very, very common issue with people with shoulder dysfunction, is that their scapula doesn't stay in place or doesn't know how to stabilize as they move their arm. But if you go back one level before that, thoracic spine mobility is extremely important. Now, how does the thoracic spine move in terms of range of motion of mobility? We're talking primarily thoracic extension and rotation. You want to have great thoracic spine extension and rotation in order to allow a good upright posture, for one. Because if you're kyphotic, just imagine that. You're kyphotic, or your patient's kyphotic, you're flexed forward, and you're trying to bring your arm up into flexion. Well, how far in flexion can you go if your thoracic spine is bent at 70 degrees, 80 degrees, right? So improving that posture and improving that mobility of the thoracic spine is going to be at the utmost importance before you really start working the shoulder. So work thoracic mobility first. Now, does that mean you have to get the thoracic spine picture perfect, 100%, 40, 50 degrees of rotation on each side when you do like a lumbar locked thoracic rotation test? No, not necessarily. It just means improve it, make some impact, measure it, see if it's dysfunctional. If it's dysfunctional, try to improve it, and work on that first. Work on that for a couple sessions, maybe even a couple weeks if it's pretty bad, before you start doing too much with the shoulder. Your outcomes will be better. All right. Now, a little caveat on that one. When someone has a rigid thoracic hyperkyphosis, this is where our model that we do with our patients and that we teach to our doctors of segment, posture, movement really comes into play. The segment is our chiropractic part. That's what we do with a vertebral segment or an extremity joint. We're adjusting the segment to get it moving properly, improving motion, and in some cases, changing physical alignment. All right. Now, that's segment. Posture is handled with postural corrective exercises or spine remodeling traction. In our clinic, I've been trained and I've followed chiropractic biophysics. I'm a huge advocate of that. I promote it all the time. I tell doctors out there, if you want to learn posture and curve correction, seek out chiropractic biophysics. That's going to be the absolute best, in my opinion, way to learn this stuff and to master it. And then functional movement, that's the stuff that we teach in Move Now University. We teach you how to put all this stuff together, how to communicate it to a patient, think about it clinically, actually execute it in a clinic, have a self-running exercise department. So you as the chiropractor can focus on adjusting your patient, case management, and doing what you love to do. And you're not guiding people on exercises all day long. I rarely, if ever, do that. You know, I'm not in there telling people how to exercise because I have a highly trained staff that does that. So the caveat that I was going to say is that if someone has a rigid thoracic hyperkyphosis, you could do all the movement stuff in the world with them, but that person may need curve correction. They may need to do home care. If you have in-office traction, you could do in-office traction. Again, I've said this before, if I had to prioritize, if you're starting from an adjustment-only chiropractor right now and you want to start adding functional rehab into your clinic, I would use the time, energy, and space to do the functional rehab. And I would look into doing spine remodeling traction for home care. Okay, so like you can use wedges and things like in the thoracic spine, there's a thoracic dental roll. You get that through chiropractic biophysics. And you use that little wedge, looks like a piece of cheese, it's a triangle, you put that in the mid-back, that's their extension traction in their mid-back. Now, in our program, we teach how to do spine warm-up exercises. So there's like a sequence to warm-up exercise for the thoracic spine using all types of functional movement, mobility, cues and processes prior to doing that spine remodeling traction at home. And then we even go a step further of teaching ways to now load that pattern to get the motor control part in place. So it's taking the best of all these worlds, the segment, posture, movement, putting it all together so you have an excellent approach for your patients so you can get the best results possible. Anyway, I'm gonna leave it there. This was talking about the 4 different laws of functional movement. Hopefully that was helpful for you. If you have any questions or if you want to see us cover other topics, please reach out, let us know. For more information, you can go to movenowu.com. And this is Dr. Todd signing off. Thanks for joining us. Over and out.